interesting thing, that the longitudinal ligaments can not only stop flexion at this joint, they also stop extension, which is very, very strange. That here we have a ligament that can stop movement in two totally opposite directions, for the tilt here and for the rise up that takes place here in the extension. So, what do we need to know about the alar ligaments? Well, I won't give you a little mind map on this because we haven't got time. We know now that the alar ligaments don't just go up like this to the sides of the foramen magnum. They go in all sorts of different directions. They go here and here and here. What determines this? Whether they go up, sideways, or down.
The height of the dens?
That's correct. It's entirely due to that. Now, Sandy, you're on a roll. I can see that. So, what other thing do we need to know about the new material as far as the alar ligament was concerned that we didn't used to know? Like its variations.
I mean, as far as the angle, like...
No, where is it attached to? Not in detail, I mean sort of the exact bit of bone, but which bones does it go to?
It's just
Goes to the occiput.
to the occiput.
It goes from the axis to the occiput. Does it go anywhere else?
Well, I think it could maybe go to the atlas.
Yes, it does. And this is the sort of work that Punjabi and Dvorak and various people have been putting out, that looking at this bottom picture here, we can see that there are all kinds of variations. There's these fibers, I can't quite see what point these would have, whether they would interfere with anything, but these are the ones that go to the occiput, but we also have fibers that go down onto the atlas as well. Now, these are not in everybody, and the trouble is that when we're examining people, we don't know whether it's this group, that group, that group, do they go to the atlas? And then we've got the angle that goes sort of more posterior or anterior. For the average, which way do they go? More posterior, straight, or anterior?
Posterior.
More posterior. How do you know that?
Because the alar ligament is commonly found more tense in flexion.
Wonderful. Excellent. Excellent. I think we can all go home. I think we can all go home. Okay. Now, this last little bit, this is for Chris's benefit. Okay, we were discussing this sort of translation and side bend and all this, and here's one of, have I got that on the right way up? Yes, hello, better put it the right way up. Okay, that when we look at, what are quite excellent diagrams sometimes with Kapanji, but they're kind of things that are wrong sometimes that you see as well. But as we've got this side bend motion, okay, at the atlanto-occipital joint, we know that we produce a rotation at the axis. Now, here's a question for you, and this is going to have clinical significance. That's why I'm going to ask all of you, all right? Is it possible to side flex the head like this and not rotate the axis? So could I say to you, right, I want you to get the head in such a position that you can manipulate it, but I want you to leave the axis in its middle position. Now I've asked that a roundabout route so it obscures the answer somewhat. Or does side bend of the head always mean we get rotation of the axis? Okay, Kelly, you're on, because I can see you know the answer.
The test that we do for the alar is that it should, the spinous process should move as soon as you go into
Yes,
scan.
yep.
So according to that, I think the answer's no. I forgot how you worded the question.
I said, is it possible under any circumstances to side bend the head and not produce rotation of the axis if all the structures are intact? And I'm not trying to set you up here. We've got an intact dens and an intact alar ligament mechanism.
So if they're all intact, then no.
Now you sound very, very confident on that. How about the rest of you?
No other move is taking place.
Or what are you trying to treat?
What are you trying to do?
The manipulation thing was a total red herring. I mean, I'm just saying that if I said to you, I want you to leave the axis in the middle position, would it even be possible to do it?
Yes.
Or is it, how would you do it then, Ralph?
Combined side bend and rotation.
Correct. So, when this produces a rotation of the axis, it's because we prevent rotation taking place this side. So we've got to have side bend and rotation taking place. But if we allow side bend and rotation to take place of the upper component, the axis will stay in its middle position. Just try it and see what happens. Just feel your partner here. And let's see, by coming into here and just doing that, get immediate movement. All right? And then if I do that, can I leave the axis totally in its middle position? What do you say? Yes. So when we are doing this manipulations and so forth, and I say leave the axis in the middle position, we can do it by allowing the side bend and the rotation to occur in the upper part of the lever. I asked that in a roundabout way, just so that we could...
So the axis can stay in its middle position with regard to rotation, but the AA joint has still rotated.
No.
No, because you let rotation occur too instead of straight side.
Mm-hmm. Because we've allowed the couple to take place. Now, has that rotation occurred at the AA, or has it occurred within the mechanism of the occiput on the atlas when I do that? Is it possible? Certainly it's possible if you do it, you know, like this and like that. I can absolutely produce that motion, no question. And I think it may be possible to produce it artificially. I'm not sure that people can actually produce the motion of rotation at the occiput on the atlas voluntarily with the axis not fully, or the atlas not fully in its rotated position. I don't think it's possible, but I think we can do it artificially. Because I think we can make sure that it takes place at the occiput working on the atlas. For example, I could come into Chris with this here, and I could get into a manipulative position and do that there, all right, and not allow the atlas to move at all on the axis. But I'm producing a rotation, as you will see, on the occiput on the atlas in the presence of a side bend that way. That's the way that the technique works, just doing that. It's one of these happy things that two things, because of your body position, works perfectly well. So it is possible to produce, to leave the axis in its middle position, provided we let the couple take place in the upper component. Good.
I guess if the axis is staying still, and there's movement of the atlas, then the joint has moved. I'm still missing, I don't know how you can stop movement at the AA joint without stopping movement of the atlas and moving the occiput.
I'm not saying you can. I don't think you can voluntarily. I think you might be able to do it by just doing it in a passive way like this. In other words, I can hold his atlas and stop it moving, and I can do those two motions there. And it's not, the atlas is not moving. That means that if the atlas isn't moving,
Okay, so you're stopping the atlas.
I'm stopping the atlas moving on the axis. Now, if it's easy to see that the axis hasn't moved, because we can just feel it. So long as I get the side bend and rotation in the correct couple, then the alar ligament tension is just maintained at its optimum level when I go like that. But if I keep the head still in its coronal plane, which is how we do the test like this, a rotation's got to take place somewhere. It's not taking place here, so it's got to take place by pulling the axis around. And that's what the test is. And if it doesn't pull it around, when we can see that we're not getting the side bend in the rotation in the face, then it means something's happened to the dens or the alar ligaments. Is that reasonable?
No, I
No?
don't understand, but we can talk about it.
Okay, all right. Now then, last thing on this sort of discussion here is this. You know, we talked about side bend. I'll put the picture up like this, okay, and then I'm going to turn it around, because it's a little easier to understand if we put it this way around, looking at the bottom here. Because in this one, we've got a rotation to the left, as you see, of the atlas coming this way, a rotation to the left of the atlas on the axis. And we get a greater movement that appears between the dens and the facet here of the atlas, as compared with that side. See that line there and that line there, there's a much greater space. And the question is, has that slid like this? Is there a translation of the atlas as we go into this sort of rotation in the same direction as the rotation? What Punjabi and White say is that it is a artifact, when we do this, of the X-ray. And it's merely that these surfaces here change their shape in terms of the orientation. And it looks as though this has slid that way, when actually it's a change of the orientation of the facets, which give the appearance on the X-ray of a side glide to the left. So we're still back now to, is there a movement to the left of the atlas on the axis when we do any of these movements in the same direction, which we've always we've sort of thought about, and they're sort of suggesting that in actual fact it's not so much a slide glide, but it's a change in the orientation here, and it's an X-ray artifact of a side bend movement in this direction. So we've got that to sort of think about, because in another part of the text they have a 4-degree movement represented on some charts that they have there. So here you see we're still struggling, and this is the latest edition just out about all of this stuff. Okay, let's just regroup now, having had a little bit more of a discussion there than I'd kind of intended, but it's important we do it. Okay. Do you remember when and we'll do this in all parts of the spine, we've got our scan and we've got all this kind of stuff, and we've decided on a group of things that we should do. Now what we need to do is to sort of say to us, what are the minimal acceptable tests that we could do to this area prior to doing a manipulation? What would you feel comfortable that we've covered prior to deciding this is suitable for manipulation? So let's just see how you do with that, the same as we did with the spine, the cervical spine, and let's just see if we can get a little flowchart, an algorithm for tackling this area. And then we can just get straight into this and then start learning the techniques. So you first thing it seems to me that's important to do is to determine the segment. Now, what was your particular starting point on here?
The vertebral artery and ligamentous test.
Mm-hmm.
Were what we started with.
Okay. But you need to have some movement and some idea before you start. So are there any sort of gentle things that we can kind of do to give us an idea of what level we're going to be dealing with here? So here's the problem. All right, let me give you a distinct problem. That the one that we discussed was, I've got a restriction of side flexion to the left. Now we know that this restriction of side flexion to the left is materially going to influence the findings of all of the shear tests. Because unless we've got the movement, the test means nothing. It could be the stiffness is protecting the ligament. Now, how is it that we know now that this can be a problem of the side flexion ability to the left of the OA, a rotation side flexion restriction of C2 on C3, or a restriction of atlas on axis to the right. all of those would cause exactly the same problem, which is an inability to go down like this. So is there any way that we could sort of focus in on this to do independent movements? That's how I would tackle this. And we're only looking at a very small range of motion that we have to do to sort of clarify, okay, this joint is moving a little. Because if we can't do that, we've got to sort of think that the joint is kind of blocked. And if it's giving a little bit, we should have a little bit of movement here. So what I would suggest for this is that the joint that is very easy to test independently, because it can take place even if the craniovertebral in the anatomical sense is fused, we should be able to look at side bend rotation of the C2-3. If that's stiff, there's probably not much point in going higher until we've done some mobilizing on it and see if we can influence this. So I would have a look at this motion here, and I'm looking at the ability to go into right side bend. My first thing to do here, if it wouldn't go, would be to palpate out the 2-3 joint like this and have a look at its ability to rotate and side bend in the couple position, just a little movement like that. Because if that little movement is present, that wouldn't stop solidly that motion there. So I would look at 2-3 very gently like this, and I'm not threatening anything here without doing all these stress tests. After all, we used to do Cyriax manipulations with extension and goodness knows what without even knowing about the stress tests here. So we're doing just that little movement. The next thing I would do is to come up very gently to C1 on C2, and we know we can get a few degrees of rotation, perhaps up to 10 to 15, without having to get any side bend. So I would do a motion like that at C2 on C3.
Are you just checking the right side now?
I'm checking just the movement that occurs, that's all. And of course, if we were doing that, it would be the ability of this to come this way that I would be looking at. Yeah.
C2 and C3.
C1,
or
C2.
Sit a C1 on C2. So I've looked at that motion, the right side flexion, right rotation of C2 on C3. I've looked at the left rotation of C1 on C2. And if that is mobile, by exclusion, we've got to think that it's at the occipito-atlantal joint.
Is your example that, I thought you said the example was that side bending left was...
Oh, okay, change it quickly. Side bending right. When I got up to Clay here, I changed it, because I was standing on this side.
So when you check C2-3, side bending rotate to the right.
To the right. C1, C2, in that first part of its movement, about that 10-degree rotation, which is an independent rotation, not necessarily have to be related to the side bend. Okay, and if that's present, then we would assume that it is at the upper joint here.
How many isn't it more than 10 or 15?
Yeah, it may be a little bit more, but even if you can get just 10 or 15, that would be sufficient to go with that side flexion, so it clears it.
And you're doing that in neutral.
I'm doing that in neutral. So we don't want to, when we're not sure about anything, we don't want to be doing very much stressing here. So I can do this, I can do that, and then I could, last of all, what Evian sort of talks about, although there's not really very much point, and so now I'm right up into the occipito-atlantal joint, and I can look at the ability to side bend, or I can couple it in with the ability to rotate, because if it'll rotate at that end range, presumably there's sufficient side bend movement to occur there. But I do this purely by, he goes from 2-3 to 1-2, but I don't know quite what the point of that is, because if 1-2 is the occipito-atlantal joint is the one that's stiff, if it's stiff, we still don't know whether 1-2 is stiff. So I think it's better to go up sequentially from below upwards myself. And so if any of them are stiff in the lower groups, there's no point in going higher, because you know that they will stop the movement, and the treatment would be to start in these lower joints. So if 2-3 was stiff in this way, then I think we are having to do some treatment down there before we spend very much time trying to do all the tests in the upper part of the spine. Yes, Bob?
When you got up to OA, it looked to me like you were testing rotation and side bending to the same side.
I was doing this motion like
So you
that.
did rotation right as well as side bending right?
No, I'm doing rotation left.
Oh, okay.
Yeah, rotation left. If I wanted to do this, I'd have to tilt him that way. Didn't you get that subtle little thing there, Bob? There or there? What? Well, I'm just... I'm coming here like that. Okay, so I'm side bending right. Now I'm...
Right, got it.
Okay? You got to be quick. So that's how I would start this off, just sort of coming into those soft little movements. Then we do the ligamentous tests. You're all happy with the ligamentous tests. Did anybody read the Sharp-Purser thing? Oh yes, going to be part of your reading in the future. Now, with looking at this, there's two sets of diagrams here, and I think they can be a little off-putting actually, that we've sort of spoke about this, okay, and we've got modifications on this, so let's just go over this, that they invite the patient to take the head into flexion. All right, and they let patients produce the abnormal findings. Then they're putting their fingers on the back of the atlas and just taking the head here and pushing it backwards like this. Okay, and seeing if there is a relocation slide as I come back.
Back of the atlas?
Yes, of the atlas going backwards, and then you've got the relocation of the anterior arch of atlas against the dens. So it's the head here, pushed there. Now, what have been the modifications of this that we've done over the years? We've taken it forward like this, and then we've held it there, and what have we done with the axis? We've taken the axis forward like that. So we've relocated the axis now, the dens, against the anterior arch of atlas in the flexion, and see if that improves the situation, rather than, as they did, to come back into that extended position. Now then, if I take Chris for a second, and just let me point this out, and we'll take it on this table here, you'll be all able to see all right. One of the points that might be significant here with a loose transverse ligament is that Chris will get down and he will adopt a characteristic position, which is to support his head with his hand, okay, to keep the lordosis. So as he goes down like this, it's possible that, you know, he wants to keep this in that position, rather than to allow the head to come into this position, which is putting stress on the anterior arch. So it'll be up in that position there. So that's a sort of a position that perhaps to be careful about if patients are really trying to sort of hold that extended position for themselves. Now, when we went into this position, there was the same test, wasn't there? We can take the head forward like this. We can come onto the arch of the atlas and we can push it forwards. Sorry, the arch of the spinous process of the axis, and we can push it forwards to relocate the dens against the anterior arch of the atlas. That is Evian's test. The patient flexes the head, you come onto the axis, you take it forward like this to see if you can reduce any symptoms. Now, what are you doing about the... Well, let's come to the tables here, because you look as if you need a stretch. I think you're falling asleep. It's murder, actually, isn't it, for physiotherapists that move all the time. They did a thing of physiotherapists who can't concentrate for more than 15 minutes unless they're moving. Now, what is your feelings about doing the tests in the various positions for the alar ligament in lying? Is that how you do it? Or do you do it in sitting? Is it as good? Is it as replaceable?
Does what replace what?
The lying test, doing this for the alar ligament, is it replaceable sitting and lying?
You could use a different grip, supine, instead of just trying to grab a spinous process, wrap around the whole business.
Step forth, maestro.
Me and my big knot.
Okay, Ralph is now going to demonstrate, and he's your representative. Okay. Would you all agree with the technique, or did you not like it?
One of the differences would be that if you're doing it in sitting, you have the weight of the head coming down.
Mhm.
The joint could probably move further. I mean, theoretically, compression, you get more motion at a joint. But if you put some compression through the head while you're doing it in supine, then that should make up for it.
Yeah.
It's the only difference I can see. I don't
Yeah.
know exactly.
How about the rest of you?
More muscle tension in sitting.
Yeah. How about pure, not looking now for fiddly little things, how about pure efficiency of doing the test in terms of your stabilization? Because when we're making comments to people that you've got this lax alar ligament, we could be creating functional difficulties if we kind of misread these things. How easy is it to stabilize the axis in the lying position for most of you? Very hard. You're working through this, and this is nothing like as strong, I don't think, in this position. I think this is reasonable. If Chris had had an accident, like yesterday or something, and I said to him, look, what I'm going to do to you now is probably more than should be done, but we need to know the answer to this question. So I'd just like you to just put up with this for a minute, and to sort of just come into here and do a test like this and just see that it's moving. And I would be from each side. And I would probably think, okay, we moved, the axis moved. I'm not looking at the total strength of the alar ligaments, because I don't really think that we should be doing stress tests just after a motor vehicle accident. But we don't have to sort of be totally concerned with immediately sending back for all kinds of tests, as we do it if we did this and nothing actually, this moved, but nothing happened with the axis. It's sufficient movement for me to feel that the alar ligaments are there and that the dens is okay. So I think that's okay. Now the question is, can I efficiently stress the alar ligaments in the lying position? When I'm trying to hold like this and stop it moving at all, and you saw how awkward it was for Ralph when he was kind of lifting the head up, and it is for you, you're standing the weight of the head. But Ralph, if you just sit down there for a second, it seems to me that to just come into this position and to hold that like that and to do that is so much more efficient than trying to do it in the lying position. I've come to the conclusion that you can hardly tell anything in the lying position, especially when your fingers are up like this and you're trying to stop that moving with these two little digits, when you know that when you get round here and you do that, you've really got to put some compression, or not compression, I avoid that term, that you've got to put some stabilization on the axis to stop it moving. If I were just doing it like that, it's very